from the American Academy of Pediatrics.
An estimated 13 to 20% of U.S. children have mental health, emotional, and behavioral problems.
A new clinical report examines how pediatricians can best screen for these problems in their patients.
Seeing kids over time punctuated by, using standard screens, you have such an opportunity to both identify areas of problem and alleviate suffering that children may be experiencing.
Plus, we'll look at how emergency medical services respond to school-based emergencies.
One of the questions that's on my mind then is how can we, better systematize this preparedness as opposed to having it be fractured with some schools being ready and some schools not.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a discussion about screening for mental health, emotional, and behavioral problems.
David, my kids are still young, but I've talked to you before about how I worry about their mental health because we live in a more technological and complex world than the one I grew up in.
Yeah, I have watched my own kids work through mental, emotional, and behavioral issues, and it's hard to help but navigate those, so you have to give yourself grace. I'm lucky I have a partner who is patient and curious and wound up specializing in pediatric mental health. It's given me new insights into how children are treated and diagnosed.
When I think of how much primary care pediatricians support families' mental health, I really admire my outpatient colleagues even more.
It's certainly a growing part of pediatric practice for so many of us. Fortunately, the AAP just released new information on it, promoting optimal development, screening for mental health, emotional, and behavioral problems, clinical report. And even better, today we get to hear from the lead author.
That's Dr. Carol Weitzman. She's co-director of the Autism Spectrum Center, a developmental and behavioral pediatrician in the Division of Developmental Medicine, along with being an associate professor of pediatrics at Harvard Medical School. Carol, welcome to the show.
Hi, thanks so much for having me.
So, mental health, emotional, and behavioral problems, or MEB problems for short, have been described as rising to crisis levels. And it's a topic we've discussed before on the podcast. Could you give us an update on what the scope of this problem is?
Yeah, it's really a staggering problem in that anywhere between about 13 to 20% of kids in the United States have some kind of mental, emotional, behavioral problem. And that there's actually even additional kids who may have some symptoms but don't quite rise to the level of meeting, diagnostic criteria for disorder, but mental, emotional, behavioral problems are interfering with daily life and functioning. So it's an awful lot of kids who are really afflicted with these MEB problems. And I think also when we think about issues like suicide, and I imagine you've probably talked about this on this podcast, those numbers are kind of increasing fairly exponentially as well. Certainly, COVID had something to do with this. Things weren't great before COVID, and once COVID hit, things really spiraled, and I don't think we've really fully recovered from that.
Pediatricians wind up being the first point of contact for so many of these children when they're talking about these issues. How well are we doing in screening for and recognizing MEB problems?
I actually think we're doing better than we've done in the past. A lot of practices have embedded screening into their routine care. Just as a side, I think that pediatric clinicians are critically important to this process because they see kids so early on and they see kids over time. And when it's all going well, they're seeing the same person over time. So they're building a relationship with somebody. So pediatric clinicians, to me, are just so optimally placed to be the ones to do this kind of screening. I think we're doing better, but I think the purpose of this clinical report was to lay out kind of a strategy, quite honestly, from birth till you exit childhood.
Are there barriers that keep us from doing better with these screens?
Well, how much time do we have for this podcast? so many barriers. Where shall we start? There's so many barriers. Let's talk about the big ticket barriers. There's payment barriers. It's time consuming to screen. It is not just simply handing someone a questionnaire and looking at the results. Screening can open up a lot of conversation, and the payment issues are not insignificant. Number two, I think there's often workflow issues. Who's doing the screen? Who's scoring the screen? Are they in multiple languages? Are they culturally relevant? So there's all kinds of issues around the screens themselves and the workflows. And then one of the biggest barriers is now you're the clinician on a busy day and you have a positive screen and you don't know where to send this kid. There are not available MEB providers. And you're sort of left, if you will, holding the bag with what am I supposed to do, particularly when you have somebody who screens, with very high positive scores. I would say those are a fairly significant number of barriers.
And I think at some point we all learned the criteria for a useful screening exam. Would you say that screening all children and adolescents for MEB problems meets those criteria?
We think we should be screening kids starting right when they are very, very young children. In the clinical report, we advocate for screening starting right from 6 months of age on, and I'm happy to talk about that. But I think when you have a high prevalence problem and you know that intervention can alleviate symptoms, then I would say that there is good value to screening, as long as your screens are appropriate for the population that you're using them in, and the psychometrics support using those measures.
And you mentioned starting screening as young as 6 months. What does that look like? And is there ever a point in youth when we should stop screening?
So the reason to start early is that by screening, first of all, we start by screening looking at maternal mood, maternal depression issues, which can be so interfering with being the parent that you want to be. And so when we detect that, we can try to help to bring people to services and supports to alleviate symptoms so they can be the parent that they want to be. We then can move on to doing screening, and early screening for very young children is really looking at fit, if you will, between parents and children. And it doesn't mean that there's honestly anything wrong with anyone necessarily, but it's saying something about the dynamic between this parent and child. Something may not be clicking quite right. And sometimes we need to help to support that, to improve, again, early attachment, et cetera. As we get a little bit older, I think we often, very notoriously, quite honestly, dismiss young children who may present with fairly extreme behaviors as being normal. Oh, those are tantrums, they'll pass. Oh, terrible twos, my least favorite phrase, but terrible twos. These things will pass.
I like to call them the terrific twos. I'm entering those now.
Yeah, well, they're called them the terrific twos because they are, right? They are. And no one in my presence ever uses that big phrase to describe a period of childhood. But anyway, we dismiss that sometimes as being, oh, this is normative behavior. And it's not always normative behavior. And we know that kids who present early on with very significant behavioral challenges are much more likely to have enduring problems. So early detection can maybe alleviate, prevent, reduce the development of that. When do we stop screening? Oh, I don't know. Why would we want to do that? Do you think we should do that?
Well, I think a lot of pediatricians, and you were mentioning this earlier, they feel pressed for time, especially during health maintenance exams. And so are there ways for offices to follow these guidelines and do good screening without getting bogged down?
I mean, here's what I would say, and you tell me if you think this would help people be less bogged down. I think screening is an office-wide initiative. So I think that when you can do things like, for instance, sending out screens in advance of a visit, there's a number of different ways that do this, but if you can send out a screen in advance of a visit so that they come in and it's scored and it's done, it makes it easier. Number two, maybe your front desk, if you don't do that, the front desk hands it to people while they're waiting. It's done. Somebody else scores it. So by the time the clinician's walking in the room, they're not waiting. They're not administering. They're getting kind of a scored screen. So to me, screening has to be kind of an office-wide practice. And I think that can reduce some of the screen burden. But I do want to acknowledge that clinicians feel burdened by it. It's now you have this screening, you've got developmental screening, you've got autism screening, you're screening for this. Now it's not just general behavioral screening, it's anxiety, depression, suicide. It is a lot. It is a lot. I definitely acknowledge that. And so you have to be kind of clever how you do it.
You know, when I was in outpatient practice, I remember sort of dreading picking up these screens and finding one that was positive, because now what do I do? Can you talk about how comfortable primary care pediatricians feel addressing these positive screens?
I totally understand that feeling. And especially if you're backed up and you've got a bunch of people waiting, I totally understand that. Except in the case where you have a kid who is suicidal, where you must act immediately. That cannot wait. By the way, your screening protocol should never allow that somebody's not looking at those screens, that 3 days later someone sees this, highly concerning screen. I actually think pediatricians struggle with this, knowing what to do. Sometimes they feel, oh my God, I've got to fix this problem now, today. And the answer that I often would say is screening is the start of a conversation with a family. It's the start of being able to say, hey, look at what showed up. Let's talk. Does this reflect your truth? Is this what's really happening? Trying to understand and coming up with a plan with the family. For a lot of kids, that plan could be, you know what? This is raising some concerns. We need to have another visit so we can sit down and talk about this. There's nothing wrong with that unless the house is on fire. And that's not most of the time. That's honestly one of the most important parts of screening is knowing, is the house on fire? Or can we take a breath and, think this through carefully?
You did mention one of the major barriers to the screening, though, is that it's easy to feel like this kind of work is undervalued by payers. So do you have advice on how pediatricians who attend to MEB issues get reimbursed enough to continue to do this very important work?
Well, I don't think I have anything amazingly wise, and maybe you guys will have wiser words on this. But I would say, at least code for it. If you're getting denied, turn to your AAP friends for some of these coding conundrums and billing problems. We have to just advocate for improved payment when you're doing this kind of hard work. Listen, I'm in developmental peds. We know all about not getting paid for the work we do. So.
And it sounds like there's a lot of room here for advocacy. What would you like to see the Academy and members be focusing on when it comes to policy?
Let's see. I mean, besides payment issues, I guess I would say one thing I really think we need to be advocating for is, elevating the importance of these issues. That's a global thing, elevating that these issues have such lifetime implications. When you look at adults with mental health, emotional behavior problems, many of them say their issues started in childhood. So we just have to be valuing children and paying attention to the fact that children, honestly, in many ways, our children are not doing so well. And that's an important point of advocacy, is how are we going to help build children with strength and resilience? That's really the goal. I guess I would also say that I think we should be thinking about pediatric practice. This is not novel, what I'm going to say, but I think we have to think about it differently. I think we need to create these hubs where every pediatric practice has mental health people embedded within the practice, and figuring out how to make that work so that we're looking at how do we really serve families where they are, where they need to be. So we're not placing clinicians in a bind. Oh my God, who am I going to send them to? And you can kind of have a warm handoff to somebody in the practice, a trusted warm handoff.
I love that idea of a hub.
So, Carol, I have been fortunate enough to work in at least one community health center where we had such a hub, but I know that many of my colleagues, even here, don't have access to that sort of collaborative care. What do you recommend for them?
I think that it's a great point because, quite honestly, that is an aspirational thing to talk about these hubs, okay? It's aspirational. But what I would say is, quite honestly, as you create a screening program, before you start screening, make friends with at least a few people in your community that you can use as referral sources. And if you have someone in your practice, a practice manager, a care coordinator, continue to nurture those to find out, because it's constantly changing who's accepting this insurance, who's not. But honestly, you want to try to establish some relationships with people in the community so you at least have a referral source. And I will tell you, this is very difficult. I want to acknowledge that we are asking people to screen, and particularly in kind of very rural communities, it's really difficult what we're asking people to do. And I respect and honor that, like, people may say we can't do all of this, but at least we should try. Like, sometimes we haven't tried to really reach out and see who's in the community. Sometimes there's friends out there that we didn't know we had, you know.
Well, Carol, I know that pediatricians listening will be aspiring to read this entire report and implement what they can, but can you leave our listeners with one takeaway before they go do that?
My takeaway is the following. Pediatric clinicians play such an instrumental role in shaping the lives of young children. By incorporating surveillance and screening, they walk hand in hand, by the way, seeing kids over time punctuated by, using standard screens, you have such an opportunity to both identify areas of problem and alleviate suffering that children may be experiencing symptoms, and also, quite honestly, building resilience and strength in children as they grow. So I feel like I do not practice primary care. I think it's a very daunting job, what primary care clinicians are expected to do and know. I don't think I could put so much in my brain anymore. But the opportunity to truly shape the life of a child and their family, I think is really a noble cause.
Well, we have appreciated the cause of having you with us here today. Dr. Carol Weitzman, thank you for talking with us.
Thank you for having me.
To read the article, Promoting Optimal Development, Screening for Mental Health, Emotional, and Behavioral Problems Clinical Report, go to aap.org/podcast.
Coming up, we'll discuss emergency medical services responses to school-based medical emergencies. David, when your kids were in school, did you ever get a call from the school nurse?
Oh, all the time. And a lot of it was honestly malingering or minor stuff. But I do remember landing in Chicago for an AAP meeting to hear that my son Sellers had fractured his skull playing foursquare on the blacktop. What about you?
Oh my God, David, I'm so sorry. But I know that he went to college and he's doing well.
I mean, he's good now. But it was a little scary. I mean, it's linear, non-displaced, no biggie, but he was hurting for a while.
Well, so far, my calls have just been for minor things like headaches or belly aches, and our school nurse has always been great at comforting my kids and offering ibuprofen or acetaminophen as needed. I do wonder, though, how many kids, like your son, need real emergency medical care at schools?
Well, you are not the only one asking this question. Today on the podcast, we have Dr. Michael Harries. He's the lead author on a new paper in pediatrics, Emergency Medical Services Responses to School-Based Medical Emergencies.
Dr. Harries is also a pediatric emergency medicine fellow at the Ann and Robert H. Lurie Children's Hospital of Chicago and Northwestern Feinberg School of Medicine. As a former high school teacher, he has a research interest in what's going on in schools. Michael, welcome to the show.
Thank you so much for having me today.
Michael, how often are kids using emergency medical services or EMS in schools?
It's a great question, and it kind of depends on how you choose to quantify it. So on the whole, it's not happening all that often. However, if you look at all pediatric EMS calls, it's about a little over 1 in 10 of all EMS calls for pediatric patients. And so if you look at it from that perspective, it is a significant number. And there's a number of research studies that will show that on average, most schools will at least make 1, if not more, EMS calls for a childhood emergency per year.
So when you want to look at school emergencies, where do you go for that data?
Yeah, that's a really good question. And unfortunately, it's a difficult question. And so for our study, we chose to use the National EMS Information System database. It goes by NEMSIS for short. So if I use NEMSIS, that's what I'm referring to. And the reason we chose that is it was one of the only sources that we could kind of come up with that would actually paint a picture of the national school system and emergencies happening in schools, because if we actually are seeking to obtain or analyze school-based data, it's very fractured, right? Obviously, every school district has their own ways of keeping data, and then within school districts or, at the state level and what have you. And so it's really difficult to look at anything in aggregate that way. And so we tried to look at it through this unique way of specifically looking through EMS calls, again, kind of with this assumption being if there is an important emergency happening at school, oftentimes schools are probably going to be calling 911. And so we recognize this doesn't gather all of that information, but it really allowed us to understand the larger picture of school-based emergencies through that lens.
So what did you find were the most common calls for EMS in a school setting?
Yeah, so the most common were calls for neurologic diseases, and this was just a little under 20% of all calls. Second was for psychiatric conditions and or substance use. They were grouped under the same diagnostic grouping system, which is around 16 to 17% of calls. Then third were for traumatic incidents, about 15% or about 1 in 6. And then from there, systemic states was number 4 at around 12%, and then respiratory conditions were around 6%. So those top 3 of neurologic, then psychiatric conditions or substance use, and then trauma were kind of the top 3 and led the way.
And when you say neurologic, can you break that down for us further?
Yeah, of course. So we did look at this broken down, and seizures were by far and away the most common within that, as one would probably expect. It was just under 60% of the neurologic diseases calls. And then from there, other was the large category of around 23%, which, maybe did include some seizures or some other diseases as well. And then developmental disorders was about 1 in 10 within that, and headache was right under. So, kind of all the things that you would expect, but seizures being the most frequent.
How prepared are schools for these types of emergencies when they occur?
Yeah, that's a really great question. I mean, unfortunately, or fortunately, I suppose it depends on the way you look at it. There's no great answer because every school is so different, right? And so, there are some schools that are doing a fantastic job, and there's others that would like to be doing a better job, but maybe capacity or resource constrained, right? And so, I don't think it's ever a question of who wants to do a good job, but rather often who has the resources or the training or what have you to really implement like school readiness to handle these emergencies. And so, that's something that we're hoping to draw attention to from this paper, again, is just to provide some data to help guide schools as well as EMS providers on how to increase readiness. Again, not with the assumption that schools are doing a poor job, but rather how can we assist them? Because it can be really difficult from a school perspective, right, to know and be prepared for these medical emergencies when, frankly, they're not the ones that like we as providers have, been trained to actually treat these, but yet they're the ones on the ground needing to respond in the moment. And so our goal is to just help them be as prepared as possible.
I'd like to sort of focus on this idea of staff being as prepared as possible. What can they do or how well can they be trained to treat things like seizures and trauma when they occur?
Yeah. So there are a number of ways to improve that readiness depending on kind of the disease state, right? And so I think from a staff training perspective, there are a number of opportunities out there for staff to educate themselves or obtain individual training, or for schools to seek to do that on a whole staff level. A lot of that work kind of runs through the different national organizations that perhaps focus on a specific disease state. So for example, the Epilepsy Foundation does a lot of work with seizure-safe schools. If you're looking at albuterol for asthma, it's a lot of the respiratory national organizations and what have you. Or if you're looking at anaphylaxis, kind of the big 3 that we think about in terms of having an emergent medication available. They also can look through their larger organizations to provide some training. But then there's also that piece, as I kind of just transitioned to, of having medication available too and being trained on how to use that. There have been some really enlightening research studies that have examined this of preparedness of school staff to administer these various medications. And some have shown that school staff are ready and prepared, and others have shown that they're not at all ready and prepared. And that kind of goes back to some of the questions you asked me earlier of, in general, are schools prepared? And the answer is it really depends. It's kind of one of the questions that's on my mind then is how can we, better systematize this preparedness as opposed to having it be fractured with some schools being ready and some schools not.
Michael, I don't know how big a fan of Pediatrics on Call you are, but back in episode 207, we discussed safe medication administration in schools. What are the sorts of emergency medications that schools have on hand, and are they adequate?
Yeah, it's another great question, right? I think, again, the answer is going to be it's all depends, right? So to explicitly answer the question, what do they have on hand? It does depend on the school. I think more and more schools are having, for sure, albuterol on hand as well as epinephrine on hand. There's definitely becoming more benzodiazepine availability as well for seizure treatment. And then, usually there's a lot of analgesics, whether it's Tylenol or Motrin or what have you. But, focusing more on those potential emergent use of medications, I usually think of those three. There's been a lot of recent as in like the last 5 years, work kind of on the policy level too, to increase the availability of these medications in school. And so a lot of work around stock albuterol. And there was actually a big policy statement that came out from the American Thoracic Society, the Allergy and Asthma Network, the American Lung Association, and the National Association of School Nurses together that recommended stock albuterol in schools. And that came out in 2001 to essentially say that schools should just have albuterol ready for any child who needs it, as opposed to just a child who has asthma having their own. And so there's been a lot of movement around that. And similar work around stock epinephrine. It's a little bit behind the albuterol, but as of now, 37 will allow stock albuterol and 14 mandated, at least in 2022. So there's a lot of movement there. And then I would kind of think of the benzodiazepine as the third medicine that's kind of following along too, where there's more and more states passing legislation to ensure seizure-safe schools, which may not mandate the benzodiazepine being available, but provides protections for the use of it, especially if it's a physician-prescribed medicine. So that way, a school staff member isn't fearing for like a legal implication if they give the medicine that, they perhaps weren't prepared to do. But if it's prescribed by a physician, there's some protections there as well as some more education. And so those are the three that I usually think of, especially as we think about medicines that can be, life-saving in the moment for kids. And so that's a great question.
This paper offers so much information for both pediatricians and for school staff. If you had one takeaway for pediatric healthcare professionals who are listening, what would it be?
I think it's that, the vast majority of EMS calls to schools are for things that we can help schools be prepared to manage in the moment, and so I think if that were to be the takeaway, I think it's really that there's a need and a desire and some important data that shows, I think, better interdisciplinary communication between healthcare providers, schools, EMS providers can really go a long way in improving pediatric outcomes, and right now there's just unfortunately not a ton of data, again, that like at a really large level and not a lot of work that's like really seeking to improve this communication and care coordination. It's starting, but I think because of all of the systemic barriers that are there, I think there's a lot of room for continued improvement in this space. And I'm hoping that from a takeaway perspective, this paper can show that there's some low-hanging fruit per se that can really be addressed at all levels, right? From schools helping, to ensure preparedness with school staff, medication availability, EMS providers to be, perhaps better prepared around what are the most common pediatric emergencies. And then from a healthcare provider standpoint to say, hey, how can we, from our perspective, assist schools and also be prepared for children coming from schools? And so I think that interdisciplinary takeaway is probably one that I'm hoping leads to future work.
Dr. Michael Harries, thank you so much for joining us today.
Thank you so much for your interest in this work and for having me on. I'm just honored to be asked to participate.
It was an honor to have you. To read the paper, Emergency Medical Services Responses to School-Based Emergencies, visit our website at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, Joanna, we've mentioned before that I'm going to be moving to Seattle in January, and so I'm really trying to hunker down and enjoy everything there is to enjoy about living here in coastal North Carolina. And it is bird migration season right now. We've talked about the birds before, but this is like birds plus. There are so many incredible avian friends moving down the coast right now, and my camera reel is full of them, and they're just beautiful. So I'm just really enjoying our evening walks by the lake with the dogs and making Christy hold the leash so that I can pull my camera out yet again.
Oh, that's so lovely. My say has to do with nature as well, which is that we went camping this weekend and had a screen-free weekend as a family. Ooh. It was more kind of like a glamping trip because we were in cabins with electricity and showers. But it was just so lovely to not be on the iPads over the weekends because as a working parent, we kind of do use those to sort of incentivize the kids to allow us to have a little bit of free time in the mornings. Oh, yeah. But we didn't have to do that because we were all together outside in nature and it was really wonderful.
Were there birds?
There were birds, but
all right, I can definitely get behind that.
Like you. Yeah.
Well, that's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on YouTube, Facebook, and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producers and editors are Ann Johnsos and Claire Keating. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. We'll be taking a week off to head to the National Conference and Exhibition.
But we'll be back afterward with the unedited audio from our recording with Drs. Alex Kemper, Rachel Moon, and Andrea Cruz. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.